We're going to call the meeting to order and rise for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Welcome, everyone. We are now going to take the roll. Colleen?
Director Wallace?
Present.
Director Nicholson?
Present.
Director Stewart?
Present.
Director Danielson?
Present.
Director
Present.
Thank you. Dr. Epen, we are now going to consider resolution number 1127, which is confirming the canvass of votes cast in the Washington Township Healthcare District general election and declaration of election returns for Measure Z.
Mr. President, I move for adoption of resolution number 1127, which confirms the canvass of votes cast in Washington Township Healthcare District general election held on November 6, 2012, and declaration of election returns pertaining to Measure Z as follows. Measure Z, to provide rapid, life-saving emergency medical care to our local community by expanding emergency intensive care units and other facilities, provide the latest life-saving medical technologies and facilities for treating heart disease, stroke, diabetes, cancer, and other diseases, reduce overcrowding and wait times, and to enable Washington Hospital to become a designated trauma center, shall Washington Township Healthcare District issue $186 million of bonds with an independent citizens oversight committee, annual audits, and no proceeds going towards administrative salaries. At said election held on Tuesday, November 6, 2012, foregoing, Measure Z appeared on the ballot thereof, and the total number of votes cast for the Measure Z were as follows. Yes, 70,568, which is 73.4%, and no, 25,596, which is 26.6%.
Thank you, Dr. Epen. May I have a second to the motion?
Second.
Okay, any discussion? Okay, all those in favor? Aye.
Aye.
Opposed? Motion passes. Dr. Epen, we are now going to consider resolution number 1126, acknowledging the appointment of William F. Nicholson, MD, and Patricia Danielson as directors of the Board of Directors of Washington Township Healthcare District.
Mr. President, I move for adoption of resolution number 1126, acknowledging the appointment of William F. Nicholson, MD, and Patricia Danielson as directors of the Board of Directors of the Washington Township Healthcare District.
Thank you, Dr. Epen. May I have a second?
Second.
Thank you. All those in favor? Aye.
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 Opposed? Motion passes. Okay, well, at this time, we are going to have Honorable Richard Keller come forward and administer the oath of office to Patricia Danielson and to William Nicholson. Good evening, Judge Keller.
Newly re-elected board members up here.
Go ahead.
Okay. Well, they're coming up. I still want to know how you get Nancy out of town so you could get that no administrative salaries included in that bond measure. Can we take ladies first? Now here. Congratulations, Beth.
We do this again.
How many years is this now that you've been on the board?
Since 2001.
Since 2001. My math would make that 11 years, but then I'm not great in math. But
That's the same as my math.
okay. Well, I'm going to ask you to raise your right hand and please repeat after me. I, and state your name,
I, Patricia Danielson,
solemnly swear
solemnly swear
that I will support and defend
that I will support and defend
the Constitution of the United States
the Constitution of the United States
and the Constitution of the State of California
the Constitution of the State of California
against all enemies, foreign and domestic,
against all enemies, foreign and domestic,
that I will bear true faith and allegiance
that I will bear true faith
to the Constitution of the United States
to the Constitution of the United States
and the Constitution of the State of California,
and the Constitution of the State of California.
that I take this obligation freely
I take this obligation freely
without any mental reservation
without any mental reservation
or purpose of evasion,
or purpose of evasion,
and I will well and faithfully
and I will well and faithfully
discharge the duties upon which I'm about to enter,
discharge the duties upon which I am about to enter.
as you always have.
Thank you.
Okay? I'm going to let you have this because that should be yours, right? Doctor, if I can have you raise your right hand, please. How many years have you been on this board now?
14.
And it's still going strong. Okay.
We hope to keep it that way.
If you repeat after me, I, and state your name,
I, William Nicholson,
solemnly swear
solemnly swear
that I will support and defend
that I will support and defend
the Constitution of the United States
the Constitution of the United States
and the Constitution of the State of California
the Constitution of the State of California
against all enemies,
against all enemies,
foreign and domestic,
foreign and domestic,
that I will bear true faith and allegiance
that I will bear true faith and allegiance
to the Constitution of the United
to
States
the Constitution of the United States
and the Constitution of the State of
and
California,
the Constitution of the State of California,
that I take this obligation freely
that I take this obligation freely
without any mental reservation
without any mental reservation
or purpose of evasion,
or purpose of evasion,
and that I will well and faithfully
and that I will well and faithfully
discharge the duties upon which I'm about to enter.
discharge the duties about which I am to.
Congratulations,
Thank
sir.
you very much.
And I'll let you have that one too. And who gets the microphone back?
Put the judge in the middle. Oh, more? Mike, I don't know if you want to call a break for people to congratulate you.
Okay. Okay, at this point, we're going to take a 5-10 minute break so that the audience may hang out with Patricia and Bill as they please. Okay, thank you all. We're going to resume our meeting and take an item out of order, which will be the oral communications. We have a speaker tonight, Maria Vera Yee, who's the wife of Colonel Garrett Yee, who has a special presentation for us. Please come forward.
Jesus. Hi.
Hi.
Okay. Will this go down? Okay. Stand over here.
There's an available microphone right there on the table.
Oh. Hi, everyone.
Hi.
My name is Maria, and my husband Garrett Yee was deployed to Afghanistan and flew a flag over Camp Kandahar airfield in Afghanistan. So he wanted to present you with the certificate to the hospital and the flag that he had flown in Afghanistan in support of enduring freedom and the hospital. We really appreciate Washington Hospital and everything you do for our community. So we wanted to take the time to bring this to you. So should we give it to Nancy?
Be happy to accept it.
Thank you. And he would like to be here, but he's at the Ohlone board meeting.
Thank you very much.
Thank you. All right, and thank you for allowing us to do this during your meeting. Oh, wait, we got to get a picture.
Oh, okay. All right.
Okay.
I'll get the box.
Well, thank you, Maria, and we really appreciate Garrett's.
And we will find a suitable place to display
We,
this.
we
Thank you.
we really appreciate Garrett's service and your family's sacrifice, and we wish you the very best holiday season.
Exception because this.
But coming to the meetings has been a nice distraction
Thank you, thank you. Are there any other oral communications this evening? Okay, we are now going to move to the election of officers. Do we have a proposal?
Yeah, Mr. President, for the coming year, I would like to nominate the following slate of officers for the Washington Township Healthcare District Board of Directors. For President, Bill Nicholson. Actually, tonight I should say William Nicholson.
Bill's fine.
For First Vice President, Bernard Stewart. For Second Vice President, Mike Wallace. For Treasurer, Jacob Epen. And for Secretary, Pat Danielson.
Thank you. Do we have a second?
Second.
All those in favor? Aye?
Aye.
Opposed? Motion passes. So at this point in time, we're going to switch chairs, but before we do, I just want to clear up something that Judge Keller said, which could be misunderstood. The bond proceeds from Measure C are to be used 100% for the construction of the new facilities. And I think he was kidding around, but I just want to make sure that everyone understands that none of those proceeds are used for operating expenses such as salaries and whatnot. So it's been a pleasure serving you this last year as president, and I look forward to working with our new board, with the new board, which is the old new board, or the new old board.
When you're digging a hole, stop digging.
So thank you very much, Bill. Okay.
Thank you, Mike. Thank you, Mike.
Thank you, Mike.
You're welcome.
I don't know whether you want to change those name tags or not.
There you go. And I think this is your water.
This proves what is old is new again.
Yeah, yeah.
Don't mix up the sandwiches.
I think Mike ate all of this already. Great, thank you very much, Mike. We're going to proceed on with our educational session, and Nancy, can you introduce
I'm very happy
Chris
to.
Lavoie?
You're going to have two education sessions this evening. The first is presented by Chris Lavoie, RN, MS, CHC, CIP, Associate Administrator, and our Chief of Compliance. The matter of ethics training is no longer elective, it is a requirement. There is a law called AB 1234 or AB 1234 that defines the requirements for training for publicly elected officials. And Chris will be speaking to that and explaining to the board how they can get their required number of hours in. I want to remind you that Chris has spoken before the board many times. She got her Bachelor of Science in Nursing in 1972 from San Jose State University, and she began her career as an emergency room nurse. In 1992, she obtained her Master's in Health Sciences Administration from St. Mary's College. I think many of the public know her as our advisor to our Medical Explorer post. She's been that since 2003, and she's currently our Chief of Compliance.
Thank you, Nancy. So we're going to talk tonight a bit about AB 1234, the requirement for ethics training that is required for all publicly elected officials in California every 2 years. And our compliance at Washington Hospital with this regulation starts with our Code of Professional Conduct. The hospital has a very detailed code of conduct that is a requirement for all who practice here, employees, physicians, volunteers, and specifically speaks to the board of directors. The board will also be completing a web-based training on this subject, and that is there are several alternatives for that out there, and the board is currently working on that. The other thing that we do on an ongoing basis is talk about this issue. And we do so in presentations such as the one tonight. So the basis of all of this is a set of ethical principles for public service officials. And they really are quite simple: fidelity to mission, responsibility to the community that the official serves, and the principles of fairness, loyalty, trustworthiness, and respect. From those principles come a set of public service ethics laws. And the laws are complex. There are many of them. There are many facets of those laws. And they do represent a minimum standard that every public official must adhere to. But it is important to remember that the first obligation is always service to the community that the official serves. So I'm going to address this tonight based on 4 major categories of these ethics laws. And they are those related to personal gain, those related to personal advantage or the concept of perks, laws related to government transparency, and those related to fair processes. So the first is the issue of personal financial gain. And the underlying principle there is that this is about public service. Probably the most well-known issue is that of bribery, and there is a whole set of laws related to that. By definition, bribery is something offered or given to someone in a position of trust in an attempt to influence or persuade. It is a crime to solicit or receive benefits in exchange for some action by a public official. And important in this is that benefit does not just mean money. It's not just cash. It could be a job. It could be special considerations for a license or a permit or something else that someone would want. A key issue in the whole idea of personal financial gain is that of conflict of interest. And there is a fundamental principle as it relates to conflict of interest that really comes from a California case. And that is that public officials and designated employees at public entities must exercise absolute loyalty and undivided allegiance to the best interest of the entity, not themselves. So the concept of conflict of interest is embodied in the Political Reform Act, which was adopted in 1974, and is discussed in the Fair Political Practices Commission regulations. There are 4 components of a conflict of interest, all of which must be present in order for a conflict to exist. The official must have a financial interest. The conflict must be reasonably foreseeable. There has to be a material financial effect of the relationship, and it has to be distinguishable from its effect on the general public. So if everyone has the same opportunity, then it probably is not distinguishable, and as a result, probably not a conflict of interest. I think this is a helpful slide. There are 6 types of economic interest, and so when you consider whether a conflict of interest exists, asking yourself whether the matter involves someone that pays you an income, property that you own or lease, your employer, one of your investments, someone that has given you a gift, or your family's finances. And certainly, you probably recognize those 6 categories because they are reflected on the Form 700, which is the disclosure of economic interest that members of the board and certain members of the hospital community complete on a regular basis. The regulations related to conflict of interest compel impartial performance, so say that you must be free of bias. They require disclosure of certain financial holdings based on the Form 700. And on that form, an official is required to declare their conflicts. It is also important that in the course of a meeting, if you have a conflict of interest, that conflict be declared at the meeting and that be recorded in the meeting minutes. The regulations require disqualification from discussion, deliberation, and voting on a conflicted issue in order to avoid conflict. And the issue there is the belief that it is possible that simply someone's presence could influence others' decision-making on an issue. On this subject, I think it is important that we all understand that it is not the presence of a conflict of interest that is the issue. It is indeed what the official then does in terms of disclosing and acknowledging that conflict. The other thing that the regulation does is require a conflict of interest code, which we do have at Washington Hospital. In terms of best practices related to personal financial gain, be aware of the types of economic interests that can trigger, again, those 6 categories, and the need for the possibility to step aside and make all decisions based with only the public interest in mind, not your own or a member of your family. The second category is what is called the no perks laws. And the underlying principle there is that public servants should be treated like anyone else. A public servant should not have benefit simply because of their office. So perks that others offer to you, things like gifts, travel, honorarium, etc. And some of the considerations here are the need to report gifts, again, in economic disclosure. There are limits to gifts, how much you can receive in a given year. The possible need to disqualify yourself from a discussion because of something like a gift, and the possible need to decline a gift or an offer for something like travel. There is a second category, which are the perks that officials could, quote, give themselves, i.e. the use of public resources. Things like you can't use the telephone system, the computer system, the letterhead for an entity, etc. And important here is the issue of understanding and knowing that there is an expense reimbursement policy and following that policy carefully. Best practice as it relates to perks: avoid anything that might be considered a perk. It is, again, not an easy law, and so if you have questions regarding whether something is acceptable or not, seek some counsel and advice on the issue. The third category is government transparency laws, and the underlying principle in this one is that the public trusts a process that it can see. Conversely, doesn't trust something that they aren't privy to. And the recommendation here is providing the public with the opportunity to participate and monitor. Economic interest disclosure, again, a requirement of the Political Reform Act, and here again is the issue of the Statement of Economic Interest, or for Form 700, that is required by elected officials and designated employees when they take office annually and when they leave office. Another issue here is the idea of charitable fundraising. The public has a right to know who is contributing to an official and the official's favorite charities or causes. As you well know, there is the Brown Act and the requirement for public meetings. Meetings being open to assure that the public is included and is informed. There are some permissible gatherings where the board can indeed meet together, and those include conferences, community meetings, and social events. And as you know, there are provisions in the Brown Act for closed sessions of the board. And this is all based on the public's right to participate and be heard, and the reason for such things as posting of the meeting agenda. There is also the public's right to access records. That is a hospital policy in compliance with the Public Records Act. As it relates to transparency, best practice, follow the regulation carefully, and probably err on the side of openness. Lastly, fair process laws. The underlying principle that everyone has a right to be treated fairly by governmental processes. Related to fair and unbiased decision-making, there are requirements to exercise power free of personal bias, and that decisions not be related to the possibility of either financial gain or financial loss. And here again is the issue of disqualification by the official can indeed resolve such an issue. A part of this is the doctrine of incompatible offices, and this is based on the belief that there could be a clash, if you will, of duties or loyalties if an official holds more than one office. And the penalty for this, it can be the forfeit of the first office. So it's important to think about to consider this if asked to participate in another official capacity. This is also where we see the competitive bidding requirements, which I know the board is very familiar with. Those assure equal access and avoid the concept of cronyism in the granting of work at a public entity. And as you know, there is the issue, the requirement for publishing bid notices for work at the facility. Another piece of fair process laws is the issue of nepotism. There's been a number of occasions in the last few years where you've seen in the newspaper issues of public officials giving jobs to family members, et cetera. It is one of the things that's required by the Political Reform Act, and it is based on the belief that it is difficult to be fair and unbiased when indeed you are dealing with members of your family. And so best practice as it relates to the fair process laws, consider all of the information on a subject in a fair and unbiased way before making a decision. And so just a couple of closing thoughts. As you know, public officials are stewards of the public trust, and earning and holding that trust is based on careful attention to both the principles and the laws that we've talked about. And remember that ethics training is, and always has been for this board, an ongoing process. Questions?
Thank you very much, Chris, for another lucid and concise discussion. Any questions from the board members? Okay, thank you. At this point, we'll move on to our next educational session. Nancy, if you could introduce Mr. Clark.
This evening, we have Steve Clark. He is a principal with the firm of Steve Clark and Associates and is the director of the District Hospital Leadership Forum, which is a relatively new group of district hospitals that have gotten together to look at some of the more challenging aspects of federal and state reimbursement. In his capacity with Steve Clark and Associates, he provides consultation on Medicare and Medicaid reimbursement and the Office of Statewide Health Planning and Development, financial accounting, and reporting issues. His expertise in the healthcare industry is recognized by the major hospital associations, both at the state and federal level, which utilize his services in evaluating and responding to regulatory and legislative proposals and mandates. He serves both hospitals and healthcare associations as a technical expert witness in OIG investigations, state administrative hearings, and court proceedings. For individual hospitals, Steve provides assistance in Medi-Cal disproportionate share hospital analysis and qualification and evaluation of hospital systems for capturing, reporting, and documenting required data needed for reporting charity care. He's also been instrumental in assisting various hospitals participate in county-operated low-income health programs to achieve increased federal reimbursement for treating the uninsured. He helped establish the firm's consulting practice after 8 years of service to the California Hospital Association. In his capacity as director of the District Hospital Leadership Forum, he provides management and technical policy guidance to District Hospital Leadership Forum on matters of finance and reimbursement, in addition to providing focus and direction for the forum's efforts to protect and maintain district hospital existing reimbursement levels. He seeks to find new and innovative approaches in an effort to enhance and improve the reimbursement levels for district hospitals. It's with great pleasure that I invite Steve to the podium.
Thank you, Nancy. I want to thank all of you for inviting me here today to give you a short overview of what the District Hospital Leadership Forum is all about. I do want to thank Nancy and Chris for their participation with the District Hospital Leadership Forum, as you've been involved from just about the beginning, and we very much appreciate that. The District Hospital Leadership Forum, I wanted to give you a quick overview of our executive officers. They are a good cross-section of the district hospitals statewide. Lindsay Mann from Cahuilla Delta is our president last year and this upcoming year. But what I wanted to do today is I want to give you an overview about the forum, some of the background, talk about some of our past, current, and future initiatives, things we're working on now, what we've accomplished to date, some of the strategies we're taking a look at as we move forward over the next year, and then more longer term as we go, to kind of give you a good sense of, again, what we're about and what we try to work on for the district hospitals. We represent the district hospital executive teams, the CEOs, the CFOs. Those are the active participants in our group. We came together in 2009 kind of as an informal structure, taking a look at how we could better represent the district hospitals with respect to the ability to participate in different funding streams that were being made available to all of the different types of hospitals, to make sure that the district hospitals' issues were voiced and that their ability to access these dollars, that they had every opportunity, just like the other hospital groups being like private hospitals or county hospitals, children's hospitals, et cetera. We currently have, and the number has changed again since I updated this slide, there are about 46 district hospitals. Now we have 39 of the district hospitals represented, 7 more to go to have a full 100% representation. We have the 5-member executive committee that I showed earlier. We have a board that is represented by about 17 of the district hospitals. Again, Washington Hospital is a member of that board. And again, it's the CEOs and the CFOs of the district hospitals that participate with us. Our main goal under the initiatives here is we are focused on looking at increasing and enhancing the reimbursement levels for district hospitals. But as we found, and you'll see in my presentation today, we found that now we're spending a lot of time protecting the interest in terms of the challenges that were faced on our existing levels of reimbursement. And there's a lot going on in that area. But when we started, we were initially in 2010 as a formal organization. Our initial focus was on what's called the Section 1115 state waiver. What that is the state of California has, in order to receive federal dollars, has to meet certain federal laws, standards, guidelines, regulations. And to do this in any kind of reimbursement program, they have to have a state plan that the federal government approves, and any changes they make to that state plan have to be approved through an amendment process. But there are certain times where some of the efforts to come up with new innovative programs or new ideas, they would be efforts that would, in essence, violate or come up against federal law. So to be able to implement those programs, the federal government gets a request from the state through a state waiver process, and in essence seeks a waiver of federal law so that they can actually implement changes that would otherwise be in direct violation. And they have to go through a very lengthy process to do that. But the reason I'm mentioning that, it comes up very key to some of the things that we'll be working on. So currently, so that's what we started with. There was, and I'm going to get into that a little bit, but there were some very large dollars that came to California through that state waiver process that we wanted to be sure that district hospitals weren't left out of being able to access those funds. However, right now, in terms of current focus, and we'll come back to the waiver, is the state's fiscal year 12-13 year state budget had a big impact on all hospitals, but had a significant impact on the district hospitals. And we've had to come up with ways to protect the dollars that we potentially could have lost if we weren't at the table to do some negotiations, which, again, I'll give you some details on. There are additional funds that come to hospitals through a provider fee. And again, the districts, we had to make sure that they were able to access those dollars. There's continued legislation and regulatory issues that affect hospital finance and reimbursement that we're addressing. And all of that, again, is to improve our future reimbursement. But I want to come back to the waiver for a second, because that's what got us going. One thing to keep in mind is that we are, as districts, we're public hospitals. And the other public hospitals in the state, which are defined as designated public hospitals, are the county hospitals and the UC hospitals. It's important to note those public hospitals along with the district hospitals as public hospitals, because in most of the funding streams that we're going to be talking about, it's going to be a sharing of dollars in a pool that goes to public hospitals. And how we can get our share of that is what's going to be important here. It should be noted from a geographical standpoint, of the 58 counties in California, 19 of them, the only public hospitals are district hospitals. And in another 9, the public hospitals are both UC or county and district hospitals. So district hospitals play a key role in many of the counties in California. One important aspect in all of these programs I'm going to talk about today is that public hospitals can, and not private hospitals, but public hospitals can access federal dollars using 2 sources of funds. And so I'm going to explain what those are, because those come in very key to all of this. One is called an intergovernmental transfer program, or I'll refer to as an IGT, but it's an intergovernmental transfer program where the public hospital, or the district hospital in our case, puts up money, and that means transfers money to the state of California, that transfers it to the federal government. It gets matched, comes back, so you put up $1, comes back as $2, and allows additional funding, therefore, to be available. A second program that we're using is called, well, I have CPEs on here, but stands for Certified Public Expenditures. And just like the name sounds, these are expenditures that a public hospital, again a district hospital, incurs in carrying out the services that it provides. The federal government will match those dollars if they are public expenditures and the public entity certifies those public expenditures as being truly incurred by a public entity. So two key points in all of these programs will be, how do we draw down federal dollars using our ability to use intergovernmental transfers and certified public expenditures? Until recently, district hospitals did not participate in most of those programs that allowed for those matching dollars to occur. There were, I don't want to get into a lot of detail. There was one program on the Medi-Cal outpatient side where we were using that mechanism, but up until this waiver process, that didn't occur. These two slides pretty much are just the maps of the California counties where I was saying where we had overlap with other publics or where we're located, so they were just for reference sake. So now this is really important in terms of where we're headed. So that 2010 Medicaid waiver that I was referring to, where the state of California was seeking changes in terms of how it reimburses hospitals, it was a waiver that was amending a new waiver, renewing a waiver that was in place in 2005. It had expired. It's titled the Bridge to Reform. The whole purpose of that waiver was to help California prepare for national health care reform. All of the hospitals wanted to participate in that waiver. All of them negotiated a number of aspects to that waiver. But the end result, and this was very frustrating for us, which is why we needed to come to the table after this occurred, was that waiver, when ultimately approved for 5 years, so until 2015, basically brought $8 billion, with a B, $8 billion to California to help hospitals prepare for health care reform. It actually brought $10 billion, $8 billion to hospitals, $2 billion to the state of California. Of that $8 billion, all of the money went to the other public hospitals, of which there are, well, I have 21 on here. I think we're down to 20 now, but all to the 20 or 21 what are called designated public hospitals. $2.8 billion for expanding coverage, $3.2 billion for improving healthcare delivery systems, and $1.9 billion to help provide some additional support for providing care to the uninsured. Now, these are important points to keep in mind because, as you'll see as we go through this, ultimately we're going to start accessing some of these monies for these same programs. But at this point, in this 2010 waiver, all of these dollars of all of the hospitals in California, which I think we're close to 500 hospitals in California, 45, 46 districts, and 20, 21 other publics, went to 20 or 21 hospitals to bridge for healthcare reform. Bit frustrating from our end, I think. And especially when I point out the payments for the uninsured of $1.9 billion, of the public hospitals, our district hospitals provided 15% of the care to the uninsured, and yet we got zero. And we have 35% of the total public hospital beds. We got zero. So one of the first efforts that we did was in 2011. We did know that there was one program outside of that waiver of which funding was available, allowing us to access that funding using those intergovernmental transfers that I was talking about, where you put up money and you can bring money back. The problem was most of the district hospitals weren't aware of it or weren't accessing those dollars. Also, once we made hospitals aware of that, the law was not clear enough to where the state either had to access it or get it out to all of the hospitals. It could be negotiated if a hospital wanted to approach the state, and usually there was get something by giving up something. And so that's how that process would work. We felt it would be more responsible for the state there was no reason not to bring down all of the dollars that could be made available. In other words, if the federal government was going to make these dollars available, we ought to access them and figure out how to distribute them. And there was, based on the level of uncompensated care to all of the district hospitals, there was the ability to access $60 million in total, really $30 million. If the district hospitals would put up $30 million, they would bring back $30 million in which we could distribute. So we put that program in place. We got the state legislature to pass a bill to, mandate that the department to put together a program to do this and set it up under a formula approach so every hospital could have the ability to access these dollars as long as they were willing to put up monies. And so that program, I think, was pretty successful. It was kind of one of our first successes that brought in dollars that we weren't accessing before, and a pretty good level of those dollars. So now under this 1115 waiver, the one I was talking about that started in 2010, that had those three various programs. One was for, I can't remember without going back, but the total dollars available for expanding coverage. One of those programs was called the Low Income Health Program. Those dollars that were limited in terms of how many dollars would be available for expanded coverage. If you participated in this particular program, any dollars that went over and above the amount that was line item to be spent there, the feds would still go ahead and draw down. So remember how I was talking about that we're in essence in a pool with all of the public hospitals, the county and UCs and the districts together. In all of our efforts to try to access those dollars, that $8 billion cap, those 20 hospitals, in any kind of discussions with us, that's off the table. That's our money. Anything that can be developed or created for you in terms of district hospitals would have to be new or additional dollars. Otherwise, there would be opposition, and we would not be able to overcome that opposition. A lot of that has to do with, there's a lot of, as you probably all know, there's a lot of strength in Los Angeles County. LA County has 5 of those county hospitals and have a lot of influence, and it's pretty hard to overcome that influence. But this was a program that would allow us to bring down dollars outside of the $8 billion. It's over and above that. In fact, those who represent the counties and the UCs encourage us to go after those dollars. Those were for providing expanded coverage to the uninsured population that fell between the 0 and 133% federal poverty level. It would help improve access, expand coordination of care, and basically fit very well into the bridge to healthcare reform, because it's a first step toward healthcare reform, getting the systems in place that we're going to need to do when 2014 comes. So it made a lot of sense. Part of the problem, however, was when the state had its waiver approved, it made it very clear that the only public entities that could operate these programs were counties, which meant if there were a county hospital, it made it much more difficult for us to be able to access and participate in those programs, such as Alameda County, for example. However, I've listed them up here, a number of the district hospitals in these particular counties, I think, what have I got, 7 counties or six counties, went ahead and decided to try to work with their counties to try to be able to participate in this program, because these would be dollars, new dollars, not dollars that would come away from the county hospital. But the county has to still be able to work with the district to set up the processes to actually draw down the monies. But to draw down the monies, they didn't have to use any of their monies. We could, as district hospitals, I mentioned earlier about intergovernmental transfers, the transferring. In this case, we can draw down monies on our own in doing this, and it just has to go through them, and it uses that certified public expenditure approach. Expenditures we incurred in treating those particular patients, the definition of the to 133% population. If we incur costs, which we are, but we're not getting any reimbursement back, those particular costs we could run through the county through various processes, get those dollars reimbursed at 50%, because the feds, it's always a 50% matching program, and we can draw down dollars. Now, Washington Hospital is working with Alameda County to participate and set up such a program. I think we're very close to that program getting underway. The only drawback on that is that program goes away at the end of 2013. However, since Alameda County has already submitted its program to the state, I think it goes back to July 1 of 11, if we come on board, we can also go back to July 1 of 2011. So it'll be more than a one-year program. So I'm very optimistic that we're going to get that underway, and that's going to be some additional dollars for the hospital. I guess I started talking without looking at my slides, because that's everything I just said. So jumping ahead, the other thing related to the uncompensated care that we provide is that our analysis shows now that in 2012, the district hospitals are incurring about $90 million, the 46 district hospitals, in the cost of care that we're not being reimbursed from. We tried to introduce legislation to get some recognition for that. Didn't get very far. The legislature wasn't too receptive because most of the comments back had to do with, is that going to take any of the $8 billion that is very much needed at these 20 hospitals? And that was a hard one to overcome. So we didn't get very far with that. But then kind of a bad thing might have turned out to be a good thing. In the state budget crisis that has occurred and is occurring, before the recent elections, when the state which still has its budget deficits, but larger budget deficits, was looking for every avenue to seek funding. Well, one of the avenues they looked at is the way they reimbursed for Medi-Cal services, the county and UC hospitals. They don't have to put up any money anymore, where most of the hospitals get paid out of the state general fund. The state general fund money goes in, the federal government matches it at 50%, still costs the state 50% of all expenditures. But in the original, or not original, but the earlier 2005 state waiver, they set up a new reimbursement system for counties and UCs where they only had to pay them the federal share of the 50%. So they saved a great deal of money not having to pay the state general fund 50%. Now, this would have been devastating to those 20 hospitals, but that's part of the justification as to why they got the whole $8 billion to help compensate for those losses. And there's a lot of dispute as, are they doing better or worse under those programs? Depends on who you talk to, I think, in terms of those particular outcomes. So the state's got to thinking, if we do the same thing to the other public hospitals, that being us, the districts, we could save $90 million. And so perhaps we ought to see if we can set up the same kind of program for the district hospitals for reimbursement, but also knowing that we could not survive with those cuts without some kind of compensation or supplemental payment in return. So that's what opened the door, I think, for us, because initially when they presented this, it wasn't like presented as, how do you like the idea? It was presented as, we're going to do this to you, but we're willing to work with you to make it work. Because if it doesn't work, you know, it's not going to work for the state either. So what they decided was we can't access, to make it work and set up the same type of programs for the counties and UCs, for the districts as we do for the counties and UCs, we're going to have to come up with something very similar, but we don't have any money for that. We can't give them any of the $8 billion. And then, lucky for us and for them, they decided that when they calculated how much money they could get from the feds, and it's all based on, it's a very complicated formula, it's called budget neutrality, and I won't get into the details of that, but when they calculated it, they kind of determined that maybe they made an error in that calculation, and they ought to relook at that, because maybe if they found any errors, they might find, if they understated, there might be more money, and potentially they could set up these programs for us. And lucky for us, they found they had an error. CMS, the federal government, the Medicare program, agreed. And so there happened to be enough money to help us offset our losses. So this program, which goes into effect on July 1st of 2012, retro for almost 6 months now, is moving forward. The problem is the specifics of the program are still being ironed out, very similar to the programs for the counties and UCs, and in terms of how the specifics will actually be implemented, the federal government's going to have to approve every step of the way. That's conversations are going back and forth regularly. We're participating in those conversations. We don't have federal approval of the specific programs at this time. I still think they're a ways off. Once those programs get approved, and I'm very confident that they will, then we're going to have some retrospective reconciliation that's going to have to occur. We're going to get a hit in the first year being 12-13, but I think we're going to come out better in the subsequent periods. When the state did its budget cuts on the May revise, we were hit along with every other hospital. And our hit was going to be probably about $30 million net, because they, assuming we're able to get these supplemental programs in place, they did make an agreement with us that, and I think a lot of had to do with one of our board meetings where the director of the department came and we explained the devastation that could occur if we don't get these supplemental programs in place. And we actually didn't think he was listening too well, but we did learn from the people we deal with at the department that everything we said at our meeting, he told his staff and said, we've got to make sure that we resolve these issues. And if we can't resolve the issues, it's going to be a package deal. The cuts don't happen if the supplemental payments don't happen. So that gave us, I think, the protections that we needed. I think in the end result, I mean, others may say differently, but I think at the end result, we came out better probably than some of the other, in terms of the state budget cuts, than some of the other hospital types. Because we also did some calculations of our own and worked with the state, and we were able to demonstrate support in terms of documentation and data that the federal dollars of $60 million that they were offering us really should be $85 million. And so therefore the cuts for the first year, 12-13, would only be $14 million that we have to spread among the district hospitals. That's a much smaller percentage than, like I say, other hospital groups. But on the plus side, as we look at those same numbers, and we have, the department does agree, is we believe in year 2, 13-14, and 14-15, year 3, that those amounts will actually be pluses for us. We believe that we'll be able to draw down, instead of $85 million, $112 million, which will now turn a $14 million negative into a $13 million plus. And then in year 3, $117 million, so another $18 million on the plus side. So this, again, and we have our foot in the door on those particular programs as we go forward into the future, wanting to make sure we get our share. Because our reimbursement systems now are no different than the other public hospitals' reimbursement systems. And that gives us a lot of support for where we want to go. I don't want to go into too much detail about these programs. I don't know how much more time I have, but the main point is I wanted to make sure you were aware that these cuts went along with various supplemental programs that brought in significant dollars for us. So I'm going to skip ahead a little bit. So what the Forum Board of Directors has asked us as staff to do with respect to those dollars that I mentioned about the 85, the 112, and the 117, the state is open to suggestions and assistance from the Forum in terms of how those dollars should be spent. And so the direction we were given and the efforts we're trying to get across, it's not a done deal, but it's the direction we're pushing for, and I feel pretty positive about it, is that in year 1, 12-13, that the cuts, the $14 million in cuts, should be allocated based upon the impact of the reductions on every hospital. So if you were hit by 5%, then you should get equivalent to make up, as much of, you'll end up in the same point that you were, but we're bringing everybody up to have the same proportionate reduction. In year 2, when there's extra monies, 2 things that we want to do. One is continue to make sure that the cut is proportionately spread across those who were hit by it, but with the extra money, put a pool of dollars aside to help out the small rural hospitals, because many of our district hospitals are small and rural and really need the help. And then whatever else is left, and there will be some left, is to help the hospitals that were under a Medi-Cal contract with the state for fee-for-service inpatient reimbursement, or what was called the CMAQ contract. Your hospital is one of those particular hospitals, because you didn't have a lot of choice, but you took a lot harder hits in all those past years by having negotiated contracts with the state, but you didn't have a lot of leverage than those hospitals that didn't have to contract with the state. So it seemed to us and the board, we ought to help make up for some of that through this process and increase the reimbursement for those particular hospitals. And then if everything goes well, as we go into the last year of the 3 years, is that we think we can bring every one of the 46 hospitals up to the same percentage of cost, and believe that number could be about 98% of their costs, which I think is a pretty good number in this environment. So that's what we're shooting for. That's our goal. Another program is the hospital provider fee program. I don't know how much the board's aware of that particular program, but just briefly, the California Hospital Association has been an advocate and worked very hard on bringing funding to all of California's hospitals through a provider fee, in essence, kind of a tax on hospitals. the tax or the fee is paid for by private hospitals. The first year that this was implemented, which I believe was April '09, I think, April '09, the district hospitals received a good amount of money, didn't have to put up anything for it. It was a good program for 18 months or so, something like that. Expired on December 31 of 10. Private hospitals didn't like the idea so much that they were putting up the money for non-private hospitals. Kind of worked a way to set up for the next 6 months, and they did an extension of the provider fee. So from January 1 of 11 to June 30 of 11, they came up with a program that if public hospitals were going to participate, then they had to put up an intergovernmental transfer to draw down those dollars. And so we did that. And I can't remember the dollars, I think we drew down $28 million or something like that. Then in the new 36-month program that started July 1/11, it's taken about a year to get implemented, but it's underway now and we're getting money. We pretty much were going to be kind of left out of that deal. And we, as the forum, our executive committee had some meetings with CHA to express some concerns in terms of we need to participate in this thing. End result, however, was pretty good. We ended up getting direct grants, just like in the first 18 months, where we don't put up anything, and we're going to be able to, we're drawing down $18 million a year over the 30 months, so 18, 18, and 9. But one of the principles we have with, and seems to be agreed to by the California Hospital Association, is any kind of concepts or methodology or approaches that are provided to the other 20 hospitals ought to be provided to us as well. That's how we kind of supported the $18 million. We also noticed when we looked at the details of the data, they were getting a second grant that we weren't getting. So we brought that to the CHA's attention. They agreed, but that money was drawn down through an intergovernmental transfer. And so we basically got an equivalent grant. There's a takeoff on it that the other ones have to pay too, that they had to apply to us as well. But that's resulting in another $10 million a year, 10, 10, and 5. So we got a pretty good amount out of that provider fee grant. Now, just so you know, I know discussions and negotiations are going on right now for, well, what happens when that 36-month grant ends, because the private hospitals don't want to lose it. And I'm sure, well, I know for a fact that they'd like us not to be in it this time, or the other public hospitals. But actually, in one of my meetings yesterday, I reinforced our position of, one, we had taken a position that we agreed that maybe public hospitals, because we access money through the waiver, maybe shouldn't receive the grant money and it should all go to privates. But again, back to the principle, if you give it to one group of publics, you have to give it to us too. But then we kind of, I mentioned yesterday, I think we might have changed our position on that, because that was before we were under that other reimbursement system that's being applied to the other publics. And based on that, I think we feel like we should be part of that, receiving that grant too. So we're kind of taking a different position, I think, this time around, and I expressed that yesterday, actually. So anyway, we're going to continue to keep working on the existing reimbursement issues that are out there. Like I say, we're only in year one of that 3-year program, and we got a lot of work to do to make sure our interests are protected. But we don't want to lose sight of what we originally were put together for, and that was to let's look at new ways to still bring in new dollars while we're still doing the other activities. So again, I thank you for giving me the opportunity to kind of brief you on what we're doing. I'd like to let you all know what those efforts are, and if there's time, I'll take any questions.
Great. Thank you very much, Steve. Obviously, this is a very complex and ever-changing arena in which to work, and we're very glad we have somebody like you to help us with this. Questions from the board?
Just appreciate the update.
Thank you.
Yeah, thank you very much. At this point, we'll move on to consideration of the minutes from November 14, 26, and 28. Do I have a motion?
So moved.
Do we have a second?
Second.
All in favor? Aye. Any opposed? Motion passes. Okay, we'll move on to our written communications. Dr. Romano.
Thank you, Dr. Nicholson. First, I'd like to extend my personal and, of course, on behalf of the medical staff, congratulations to you and Patricia on your reelection. Nevertheless, we'll go to the Credentials Committee action items for November. The medical staff is recommending that you approve appointment and privileges as delineated for Grace Yu in pediatrics and allergy to the provisional ambulatory staff, Richard Nguyen, general surgery to provisional active, Andreas Kamlot, cardiothoracic surgery, provisional courtesy. Vineet Kambaj, podiatrist, to the provisional active staff. Robert Peralta, ophthalmology, to provisional courtesy staff. And Elizabeth Addy, OBGYN, to the provisional active staff. We are also recommending that you grant 2-year reappointment with privileges as indicated for Sumitra Chari, internal medicine active, John Dearborn, orthopedics active, Hanwin Do, OBGYN active, Roy Lin, pediatrics active, Deirdre Lyle, fetal OB consulting, Andrew J. Maxwell, pediatric cardiology consulting, John Thomas Mehegan, vascular surgery active, Tsuyoshi Mitari, critical care intensivist active, Bhaskari Pila, pediatrics active, Gunjan Saxena, internal medicine active, Ranjana Sharma, family medicine active, Daniel Taylor, internal medicine active, Anamali Veerapan, gastroenterology active, Phuong Tao Vo, family medicine active, to switch to ambulatory. We would like to recommend that you grant 6-month conditional reappointment from January 1st, 2013 through June 30th, 2013 for Jasbir Multani. She is currently part of a FPPE review. We would like to recommend that you grant 1-year reappointment from January 1st, 2013 through December 31st, 2013 for Dr. Richard Lee for NBC Medical Board of California action, i.e. probation. We would like to indicate that the following non-reappointments have deemed to have resigned: Sunny June and Christine Skolnick. We would like to recommend that you transfer to the requested staff category for Dr. Richard Lee, active to ambulatory, and Dr. Vo, active to ambulatory. We would like to recommend discontinuing proctorship and advancing to the appropriate staff category Dr. Vinod Kurapath, gastroenterologist, provisional to active, Thomas Lee, and Saif Siddiqui, both teleradiologists, provisional courtesy to courtesy. We would like to recommend that you discontinue proctorship for the initial core privileges for Dr. Leif Erickson in emergency medicine, Gregory Perrinet, teleradiology, and Romy Yoon in anesthesiology. We would like to recommend that you extend the proctorship and provisional category for both Suitha Kausik and Amy Toon, both in pediatrics. We would like to recommend that you extend proctorship and the provisional category for Christine Nguyen, pediatric GI. And finally, we would like to indicate that the following have expired leaves of absence and therefore deemed resignations: Dr. Piali Ditere and Martin Cass.
Thank you very much. We have a motion for approval of the credentialing action items.
So moved.
And a second.
Second.
Thank you very much. All in favor?
Aye.
Aye.
Aye. Motion passes. Any opposed? Motion passes. We'll move on to our service league report. Sharon.
Okay. Good evening, everybody. During last month, our Service League held our Masquerade $5 jewelry and accessory sale. Cherie Germondo orchestrates our twice-a-year sale, communicates with our vendor and the hospital staff as to the details of the event and the dates. She and her team inform our greater community. She gathers together hardworking volunteers to work the event. Many of these volunteers, such as Jeannie Yee, Gail Tamita, Chris Burns, and Cherie, work all day for 3 long days. We are proud to report that this year we exceeded last year's winter sales, and our commission from our vendor is $18,665. The Service League would like to thank all the hospital employees and our greater healthcare community and patrons for again making our sale such a huge success. Our spring sale is April 29th and 30th and May 1st, 2013. Also, this last month, our nominating committee has completed their work for the year and put forth a new slate of Service League board members for consideration. This consideration and vote will happen at our annual meeting scheduled for February 4th, 2013. Letters of invitation to the board, administration, and the chief of medical staff will go out shortly. Thank you.
Thank you very much. Sure. Great work. And great sale, too.
We thought so.
Yeah, good. We have our medical staff report. Dr. Romano.
I'm back. So the first page there is the medical staff statistics, indicating a grand total of 534 members of the medical and allied health professionals. Of these, 497 are active and provisional active staff members. Of note, the Department of Medicine remains our largest department with 209 total members, 162 of whom are active and 23 provisionally active. And the second department in size is surgery, 119 members, 67 of which are active, 22 provisional, and the greatest number of PAs, that number of 14 in allied health is PAs and a couple of perfusionists as well. In terms of our applications, we have 8 pre-applications in process, 17 applicants in process, 6 of whom you approved tonight, and 4 applications that are inactive. That's my report.
Growing staff. Thank you, Joe. We have our hospital calendar. Nancy.
Okay, we'll ask Joe to roll it.
Past health promotions and outreach events. On November 14th, as part of the Washington Women's Center Evening Lecture Series for Women, Dr. Aruna Chakravorty, endocrinologist, presented Women and Thyroid Hormone Imbalance. 31 people attended. On November 17th, the Washington Hospital Diabetes Center held its 5th annual Diabetes Health Fair. The program featured presentations on diabetes and your eyes, as well as diabetes and your skin, wound care. The event also featured a live cooking demonstration. Blood glucose, cholesterol, and blood pressure screenings were also provided. 103 people attended. 103 blood glucose and cholesterol screenings and 73 blood pressure screenings were performed. The Washington Hospital Healthcare Foundation kicked off the holiday season with the Trees of Angels campaign. The celebrations began on November 26th at the Bernardin Family McDonald's restaurant, when Mayor-elect Bill Harrison was joined by Linda Wasserman, widow of past Mayor Bob Wasserman, in lighting the angel tree. The crowd enjoyed a selection of seasonal favorites performed by the Mission San Jose Choir. Trees of Angels started in the Tri-City area by Al Bernardin, owner of several local McDonald's franchises, and the Washington Hospital Healthcare Foundation. The event supports Washington Hospital Hospice Care. Patricia Danielson, Dr. Jacob Epen, and Dr. Bernard Stewart represented the Washington Township Healthcare District at the event. Approximately 150 people attended. On December 1st, 250 attendees joined the foundation for the annual Children's Holiday Breakfast in Washington West, catered by the Bernardin Family McDonald's. Ronald McDonald entertained the crowd with magic tricks and jokes. To cap off the morning, Santa and Mrs. Claus made a grand entrance and sat with families to have their pictures taken. Patricia Danielson and Dr. Bernard Stewart represented the Washington Township Healthcare District at this event. Approximately 250 people attended. On December 3rd, the foundation joined the City of Newark in lighting the holiday tree on the grounds of Newark City Hall. Alameda County Fire Interim Chief Demetria Schaefer, also the president of the Washington Hospital Healthcare Foundation, spoke on behalf of the foundation. The Cougar Chords from Newark Memorial High School sang for everyone in attendance. Mayor Al Nagy lit the tree to begin the holiday season. Patricia Danielson and Dr. Bernard Stewart represented the Washington Township Healthcare District at this event. Approximately 125 people attended. On December 5th, Mayor-elect of Union City, Carol Dutra Vernacci, threw the switch to light the tree at the Nakamura Clinic in Union City. This event, which was held in conjunction with the annual holiday mixer of the Union City Chamber of Commerce, attracted 75 attendees. The James Logan Senior Jazz Choir serenaded the crowd. After the tree was lit, attendees stayed for a reception and competed in a drawing for prizes. Patricia Danielson and Dr. Bernard Stewart represented the Washington Township Healthcare District at this event. On December 6th, as part of the Diabetes Matters series, Adrian Palisak, pharmacy resident, presented Straight Talk about diabetes medications. 26 people attended. On December 10th, the Washington Hospital management staff partnered with One Child to provide holiday gifts for students in the Tri-City area. One Child is a nonprofit organization dedicated to providing disadvantaged children with new clothing and school supplies. Over 70 children will have their holiday wishes granted as a result of the management staff donations. Upcoming health promotions and community outreach events. On January 15th, from 6 p.m. to 8 p.m., as part of the Stroke Education Series, Dr. Ash Jain, cardiologist, and Doug Van Houten, RN, will present stroke prevention and other disease processes and healthy lifestyle. Be smart and avoid stroke. On January 16th, from 12 noon to 1 p.m., as part of the Washington Women's Center Lunch and Learn program, Anna Mazzei, registered dietitian, will present Healing Soup. Whether comforting a cold, nurturing a friend, or enjoying with your family, soups can be healing. 3 soups will be prepared during this live cooking demonstration. On January 29th, from 1 p.m. to 2:30 p.m., Dr. Gabriel Herskew, vascular surgeon, will present treatment options for varicose veins and chronic venous disease. This event will be co-sponsored by Washington Township Medical Foundation. The Washington Hospital Healthcare Foundation Report. Each year, the Trees of Angels celebration raises funds for hospice care in the Washington Township Healthcare District. The Washington Hospital Healthcare Foundation would like to thank all the sponsors of Trees of Angels, including benefactor sponsors Lonnie Robinson of RK Electric and Janice Futch Claridge. Special thanks are extended to the Bernardin Family McDonald's. Washington Hospital Employee Association, WIA. WIA is currently accepting donations for the Red Cross to aid in the Hurricane Sandy relief effort. WIA will match up to $1,000 in donations. WIA is also sponsoring a holiday wish tree to collect gifts for the holidays, which will be donated to Seneca Center, a local agency providing counseling services for children and their families. Abode Services, an agency providing housing and supportive services for the homeless. And SAVE, a local domestic violence prevention agency. Washington on Wheels, WOW, Mobile Health Clinic. During the month of November, Washington on Wheels Mobile Health Clinic, also known as WOW, provided healthcare services at several community sites and schools located throughout the Tri-City area. WOW provided flu vaccinations to employees of companies located in Fremont and Union City. 337 flu vaccines were administered. WOW also provided respirator fit testing and evaluations at OMG Scientech, located in Fremont. OMG Scientech is a manufacturer of chemicals used to produce semiconductors and various other electronic applications. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was November's most viewed web page. with 14,203 views. Other active sections include InHealth, Channel 78. Washington Hospital's cable channel, 78, InHealth, aired a number of new programs, including Radiation Safety, What You Need to Know, GERD and Your Risk of Esophageal Cancer, and a program on osteoarthritis. InHealth also aired several anti-texting and driving public service announcements. Other updates. Dr. Jacob Epen, Washington Township Healthcare District Board member, was recently named Medical Director of the Newark Wellness Center. The center is one of Alameda County medical centers providing ambulatory healthcare services to residents of Alameda County. On November 15th, Washington Hospital participated in a statewide medical and health disaster exercise. The drill involved a simulated 6.0 earthquake on the Hayward Fault and a power outage. As would be the case during an actual disaster, the hospital command center was activated. Hospital staff, physicians, and volunteers went through the exercise of responding to the simulated disaster. The goal of the drill is to promote safety and emergency preparedness while keeping our commitment to our community and the patient-first ethic. For more information on any of the programs mentioned, visit whhs.com or call 1-800-963-7070.
Wow. And finally, it's my pleasure to introduce you to Cristela Robles. She's our Employee of the Month for December. She's been employed at Washington Hospital since the year 2000 in her role as a registration clerk at Washington Urgent Care. She's responsible for registering patients along with other front office clerical duties. She's a dedicated employee who takes her job very seriously. She is conscientious and very kind to our patients and our fellow staff members, which is also important. She constantly and consistently gives the extra mile for her patients and coworkers and always greets everyone with an enthusiastic smile. She's married. She has 2 boys. When she's not working, she enjoys spending time with her family. She also enjoys hiking, shopping, and going to the movies. I'm very proud to present to you Cristela Robles.
Great to have her as part of the team. Any other calendar for the board? That's it, Nancy?
Yes.
Thank you. On behalf of the board, I'd like to congratulate Dr. Epen on his new appointment.
Thank you.
Thank you, Jacob. At this point, we'll move on to our quality report. Stephanie Williams is going to present the quality dashboard for quarter ending September 2012.
Thank you, Dr. Nicholson. As always, I'll go over briefly the definitions in terms of what's a goal. It's something that's measurable and accomplished and achievable over time. Benchmark is the best practice that we strive for to meet or exceed. Internal benchmark is an achievable objective of a self-imposed standard within the organization based on our previous year data. And the comparative rate is usually a rolling benchmark that retains the data from prior years and adds new data as available. One of the first measures is our patient safety handoff communication. We were at 98.7%. Oftentimes, this is where the handoff is from one caregiver to the next or from one level of care to the next. It's both observed and audit looking at documentation. So we continue to educate the staff so that we can be in compliance with 100%. Patient safety in terms of procedure timeout, again, this is another target that we shoot for 100%. We were 99.9%. I know it's close, but it's not 100%. We continue to remind the staff and discuss the current safety policy and discuss the importance of procedure timeout. And this is, again, making sure it's the right procedure in the right setting at the right time on the right patient. Falls with moderate injury. For this quarter, we had no falls, but this is always a quarter behind. We continue to have an aggressive fall program. We continue to educate the family and patient in terms of calling for help. We continue to have the rounding in terms of paying, potty, getting the patient to the bathroom on time, making sure the call lights are accessible to them. With regards to sepsis mortality, we have seen a drop in terms of our sepsis mortality. There has been new guidelines that does not reflect in this data as yet. So going forward, you may see some changes in terms of the benchmark that's associated with it. But again, with sepsis, timing is everything. Early intervention means better outcomes and getting the patient the treatment and the care as quickly as possible. Pressure ulcer, we continue. This is a prevalence study, so this is a snapshot of 1 day in time, looking at all the patients in the hospital and checking to see their skin in terms of pressure ulcers. And again, we were at the goal of at 1.2. MRSA infection, definition of a nosocomial infection is any infection that happens within 48 hours after admission. So that patient may have come in with it based on what's out in the community, but if it's not identified on admission, then it becomes that it's compounded and it becomes a hospital-acquired infection. There continues to be a lot of work done in terms of hand hygiene, screening of patients based on the state and guidelines, and we continue to do infection control rounds in terms of making sure that we are in compliance. And we were 0 for 2 quarters in a row in terms of no infections. The VAP, which is a ventilator-associated pneumonia, it's unbelievable. We have gone 1,023 days without any infections. The last time we had an infection was in December of 2009. We continue to have an aggressive respiratory program with critical care, but and based on the CDC guidelines now, we are going to be looking at new criteria in terms of defining what is considered a VAP, and they have changed it to a ventilator-associated event. So you will hear more about that in time to come. But this has been a work in terms of from the time we started with IHI, a lot of work has been done, and we continue to be very aggressive with our bundle compliance as it relates to VAP. Urinary tract infection, we had 2 infections in the hospital. For quarter ending September, we continue to do a lot of work in terms of education to the staff, looking at our current clinical practice. We are in the process of putting a team together to see how we can get that down to 0, because that's our goal. Moving on to the core measure data. This is for quarter ending September 12th, but I have also shown you what's on the Hospital Compare website. And the website was last updated in October of this year. As it relates to heart attack, I want to highlight aspirin on arrival and discharge. The goal is to get 100%. We had 95% of the patient that had it within 24 hours. They have gotten it, but they may not have gotten it within that time frame that's required. The primary door to PCI, door to the cath lab, we were 90%. There was 1 patient that got to the cath lab within 9 minutes later than they needed to be there. They have to be there in 90 minutes, and that patient got there 98 minutes. So the goal, again, is to strive. Our average is usually running about an hour in terms of getting that patient to the cath lab. And as it looked with the state and national, we are comparable in many instances and better in most. Looking at heart failure, all discharge instructions for quarter ending September, we were at 96%, and again, this includes the instruction in terms of your medications, when to call your doctor, your diet, all of that needs to be included in there. It has to be documented, and it has to be given to the patient. So it must be in the medical record in order to get credit for it. And the goal is continue to be 100%, and a lot of work is being done around heart failure. As it relates to pneumonia, blood culture in the ED prior to first antibiotics, we were at 96.9%. Every indicator that falls out here, we go back and do an investigation in terms of why it fell out and what could we do differently in the future, and we'll continue to do that as well. Some of it is documentation issue, and some of it is that, and in this case, the antibiotic was given before the blood culture was obtained, and the blood culture must always be obtained first based on the guidelines. The SCIP, which is prevention of surgical site infections, for antibiotic within an hour of incision, we were 100%. This is one where you also have to look at the prevention of blood clots in terms of getting the right prophylaxis or treatment to that patient. We were 100%. When you look at where we are in terms of both the state and national average, we were better than the state and national average in many of these indicators. Some of these indicators you will not see for later on because a few of them CMS is no longer requiring, nor is Joint Commission, and you will hear more about that as we present the next quarter data. And this is for the outpatient surgery. Again, we look at antibiotic timing and antibiotic selection, and for quarter ending September, we were 100%. And again, looking at us from the state and national, we are comparable to both the state and national average. Any questions?
Any questions from the board? Stephanie, I think that's very impressive results, over 1,000 days with no ventilator-associated pneumonia. That speaks quite highly of the team effort, which has led to that kind of result, and shows what attention to ensuring the proper protocols and ensuring that they're completed has a dramatic effect on the quality and the safety of the care that we deliver here at Washington. So it's good to see that kind of data. Thank you very much.
Thank you.
We'll move on next to our finance report. Chris Henry.
Okay, good evening. Tonight we'll be taking a look at the operational and financial results for October 2012. October continued to see census numbers that were consistent with what we've been seeing in the past few months, a little bit challenged. Our average daily census for October came in at 162. We had budgeted for 190.9. We had 1,087 admissions, 5 less than what we had budgeted for the month. Patient days came in 895 below budget at 5,023. Our average length of stay for the month, as those numbers indicate, lower than we had expected in the budget. Average length of stay for October was 4.76. We'd expected 5.42. However, utilization statistics looked better in October. Our case mix index for the month was high at 1.541. We had 191 deliveries in the month, 33 higher than we expected in the budget. Surgical cases came in 53 above budget at 436, and I believe that is our highest total for surgical cases on record. Those cases include joint replacement cases that were 36 above budget at 142. Again, the highest number we'd seen prior to this was 125 in a month. So the Center for Joint Replacement's been very busy. Neurosurgical cases came in 12 above budget at 27. Our cardiac surgical cases were just one below budget at 10. And our PTCA procedures, highest number of PTCAs we've seen in quite some time at 56. We had expected 48 in the budget, so we were 8 above what we expected for the month. Outpatient visits were 566 above budget at 9,477. And our emergency room visits were 161 below budget, but still very busy at 4,231. Looking at FTEs, we had 1,281.8 productive FTEs in the month and 179.4 non-productive FTEs, giving us total FTEs that were 43.1 above budget and 1,461.2. Likewise, our FTEs per AOB came in above budget at 6.95 in October. Moving into the financials, and as always, we'll look at our governmental accounting standards methodology, which is the presentation used for our audited financials. Total patient revenue for October came in $2.590 million above budget at $183,164,000. Our contractual write-offs for the month came in a little higher than budget at 76.42, giving us net operating revenue about $426,000 below budget at $43,470,000. Operating expenses for the month came in about $458,000 below budget at $42,038,000, giving us an operating bottom line for the month just $32,000 above the budget, but very positive at $1,432,000. Non-operating income for the month came in at $680,000, about $590,000 below budget. That was primarily impacted by an unrealized loss in our investments of $763,000 for the month, giving us a total bottom line about $558,000 below budget from a GASB point of view of $2,112,000. Pretty good improvement from what we've been seeing in the recent several months. Wanted to show you a quick look at what's comprised in our contractuals. For the month, our contractuals, straight contractuals, came in at 76.3%, and for the year to date, it's 76.03%, which is running very close to what we expected in the budget. We budgeted about 75.92, I believe, for the year to date. We have had some rack adjustments during the year. We've discussed the large one that happened in August, but in October we actually had a pickup. We gained back some of that money, about $474,000. And of course, as the government goes, the commercial providers go. We also get audited by them. In the month, they had about $152,000 in recoveries to comprise our total contractuals of about $139,973,000 in the month. Quick look at our Financial Accounting Standards Board presentation, and this is the way, for those who aren't familiar, that Wall Street tends to look at us. Operating bottom line stays the same at $1,432,000. We remove our unrealized loss in our investments and our property tax revenue, which supports the debt service on our general obligation bonds, to come up with non-operating income from a FASB perspective, $137,000 above budget at $733,000, and a total bottom line from a FASB perspective, about almost $170,000 above budget at $2,165,000. So are there any questions on October results?
Chris, just a question regarding the case mix index and the average length of stay. So we have a higher case mix index and a lower length of stay.
Right.
So is our clinical staff getting the patients better, sooner, and home sooner?
I think.
Or do we have high case mix patients which have necessarily low lengths of stay because of minimally invasive procedures and...
Yeah, I think we have a combination, and I'll go back to the statistics. As you see, our variances are in the areas that tend to be higher case mix. Joint replacements, neurosurgical cases, PTCAs, those things, cardiac business drives higher case mix. We're not seeing long lengths of stay, partly because I don't think we're seeing the long-term chronic illness that we have seen in the past, and that's bringing length of stay down. So it's a combination of those things going on that drives up that case mix index and the length of stay down.
So the high-intensity, short
Yes.
hospital stay patients.
Yes.
Great. Okay, thank you very much, Chris. Any other questions for Chris? Okay, beautiful. Can we move on to our hospital
We'll talk
operations?
about November.
Good.
The month of November saw 952 patients, admissions. They resulted in 4,709 days of care. Our average daily census came in at about 157, and this was lower than the preceding month. The high and low ranged from 180 down to 122. We had anticipated 1,013 admissions for November and 5,494 days of care, and an average daily census of 183. So we're going to come in about 385 patient days of care below the budget this month. The average length of stay for adults and children in November continues the pattern. It was lower than budgeted. It came in at 5.14. We had anticipated an average length of stay of 5.42. Our preliminary information indicates inpatient revenue for the month of November amounted to approximately $130,410,000 compared to a budget estimate of $128,856,000. Of this amount, 49.5% was Medicare and 9.2% was Medi-Cal, for a total of 58.7% government program revenue. Medi-Cal eligibility continues to lag, taking almost up to a year to get people enrolled, which I think is a huge problem, especially with the government planning to make Medi-Cal available to millions more Californians. But we'll see how that works out. In the birthing center, we saw 144 deliveries, and we had budgeted 149, so we're coming in pretty close. We had 321 baby days of care, and our newborns totaled 146. A year ago, there were 153 deliveries. In terms of surgery, I think this is the key to understanding where the revenue numbers come from between surgery and the cath lab. We had 404 surgical cases at the hospital. We had budgeted for 362. This includes cardiac surgical cases that were 5 above budget at 14. The inpatient surgical activity was above budget by 35 cases, while outpatient surgeries were above budget by 7. 543 cases were seen at the outpatient surgery center versus a budget of 531, so they're coming out ahead like we have, above budget. For the month of November, there were 434 cases seen in the cath lab, including 42 PTCAs. Total cath lab cases were higher than budget by 81, or 22.9%. And PTCAs were lower than budget by 1, or a 2.3% variance. Inpatient cath lab procedures were 33 more than expected in the budget, while outpatient procedures were 48 higher than expected. And that is a nutshell, is how we got to those numbers. Outpatient visits for the month of November were 6.7% lower than the budget. They came in at 8,168. The emergency room recorded a total of 4,178 patients, a daily average of 139, 67 above budget. The Washington, Warm Springs, Newark, Nakamura, Ohlone, and Walmart clinics saw approximately 3,878 patients during November, 305 more than was budgeted. That's an 8.5% positive variance. Our total system emergency room and clinic visits for November are 8,056, compared to a budget of 7,684 visits. In terms of personnel, full-time equivalents for the month of November totaled 1,461.9, including 2.7 agency personnel. This was 2.5 FTEs higher than the budget. The FTEs per adjusted occupied bed, however, came in at 7.04, which is above the budget of 6.14. So we still are flexing down. In summary, we had 61 fewer admissions and 785 fewer patient days than anticipated in the budget. The surgical cases came in 11.6% above budget, and cath lab procedures came in above budget by 22.9%. The outpatient visits for November were 583 below budget, while the ER visits were 67 higher than anticipated. Our clinic visits for the month were also above budget by 8.5%. Total paid FTEs are above budget by 2.5 and below the last 12 months average by 42.3 FTEs. Inpatient charges for the month were higher than budget by approximately 1.2% or $1.5 million. And outpatient charges were higher than budget by approximately $3,748,000 or a 9.8% positive variance. Total hospital charges for November were above budget by 3.2% or $5,301,000. On November 30th, there were 167 days cash on hand. The total days revenue and accounts receivable at November 30th was 59.55, which is a very good number. The days revenue and accounts receivable excluding Medi-Cal was 55.17. During the month of November, $1,848,049 of charges were approved or pending for charity assistance. So we're continuing to bump or exceed the $2 million mark a month on charity care.
A trend I'm sure will continue.
I believe it will.
Thank you very much, Nancy. At this point, we're going to move on to our action items, and our first action item is the consideration of the Chief Executive Officer Employment Agreement. We're going to handle this by Dr. Eapen first reading the motion, and then we're going to move into discussion, which will be carried or led off by Mr. Wallace, our immediate past president, and then we'll open it to public comments as a public hearing. So, Dr. Eapen, if we could have the motion, please. Item A.
Mr. President, in accordance with the district law policies and procedures, I move that the employment agreement between Washington Township Healthcare District and Nancy Farber, CEO, be extended by 1 year for a new term beginning November 1st, 2012 and ending October 31st, 2016. And that the President of the Board is hereby authorized to execute the appropriate form of amendment to extend the term.
Thank you, Dr. Eapen. Do we have a second? Second. We have a second from Dr. Stewart. And discussion. Mr. Wallace.
Yes, thank you. As you know, we are discussing the extension of the CEO's employment agreement. As the board member leading the discussion, I want to take a few minutes to provide some preliminary comments. First, I want to note what is different about our process this year. In the past, in the September-October timeframe, we would receive a report from our healthcare executive compensation consultant, Integrated Healthcare Strategies. The report would tell us the current compensation range for CEOs of similar healthcare systems. This would allow us to consider increases in the CEO's base salary based on what CEO peers were being paid. This year, we did not engage the consultant to generate a report. Due to an unprecedented reduction in inpatient census and outpatient visits, which occurred in the spring of 2012 and proceeded unabated through the end of September, our revenues were down. We have substantiated this drop in census was experienced by all of the hospitals in the Bay Area. It appears to have occurred in Southern California as well. No one really knows why this has occurred. It could be the uncertainty associated with the implementation of the Affordable Care Act or just general uncertainty regarding the economy. While October and November volumes look better, it is still too early to tell if the trend has changed for the better. However, given the reduction in revenues, the CEO has cut expenses in many areas, which included a management salary freeze. While we do not have a full report from Integrated Healthcare Strategies this year, I understand that the nationwide average increase for healthcare executives for 2012 is 3%. Our CEO made herself part of the salary freeze and elected to forego any consideration this year of an increase in her base salary. At a later date, we might consider whether any at-risk award is due under her agreement, but that will be for the board in the future to decide. The other point I want to make is, despite the challenges associated with the reduction in revenues, we have a lot to be thankful for, and we would be remiss in not acknowledging some of these accomplishments by the CEO and her staff. Measure Z passed by a higher margin than its predecessor, Measure FF. We are eternally grateful to the voters for supporting our district. Measure Z will provide the funds necessary to, as I think many of you know, but just to reiterate, they will provide funds necessary to provide local access to the latest and advanced medical technologies and treatments, enable Washington Hospital to apply to become a designated trauma center to provide the highest level of emergency care to patients, reduce overcrowding and wait times by expanding emergency room facilities, upgrade and expand the aging intensive care and critical care units, and provide state-required upgrades for earthquake safety. But in this day and age, it is difficult to get 2/3 vote on any bond measure, let alone do it in such a highly contested presidential election. The CEO and her staff did a great job in helping to pass Measure Z, the rewards of which will not only benefit the current residents of the district, but also future generations. We also won several awards and recognitions, which include, in September of 2011, the hospital was granted magnet status recognition by the American Nurses Credentialing Center. A magnet designation is the highest level of recognition that a hospital can achieve for nursing excellence. Only 6.7% of the hospitals in the United States have earned this status, and Washington Hospital is one of the 4 hospitals in the Bay Area to have this designation. In June of 2012, Washington Hospital received an A grade in hospital safety from the Leapfrog Group, which conducts a nationwide survey of medical centers. The score is based on assessment of patient outcome data in 26 different categories, including patient injuries, infections, and medication. In August 2012, the U.S. News & World Report ranked Washington Hospital as the 4th best hospital in the Bay Area. Washington Hospital was recognized for its high performance in 9 specialties, including diabetes, endocrinology, gastroenterology, geriatrics, gynecology, nephrology, neurology, neurosurgery, orthopedics, pulmonary, and urology. Washington Hospital also scored high in patient safety, demonstrating its commitment to reducing accidents and medical mistakes. As we all know, these accomplishments have occurred in very challenging economic times and are a direct reflection of the success of the institution and its leadership. From my perspective, we must reaffirm our trust in our CEO by granting an extension of her employment agreement. Therefore, I propose we extend the CEO's contract by another year.
Great, thank you very much, Mr. Wallace. Other comments by the board members? Dr. Stewart?
These are very, very difficult times. It's nice to see October and November improving. But looking back at the year as a whole, I think we'd have to say that the management of the hospital, the administration of the hospital has been really excellent in very, very difficult times. And it's nice to see these awards. It's nice to see progress on Measure Z. I think we've helped the district residents a lot. I think we've served the district very, very well. I'm very pleased to join Mr. Wallace in this proposal of increasing the employment agreement by 1 year. I think that's a good thing to do at this point in time.
Great, thank you, Dr. Stewart. Dr. Eapen, comments?
You know, the only thing that concerns me sometimes in the hospital, in the healthcare is chasing numbers. When you look at patients, inpatients and outpatient numbers, I don't think the hospital CEO or the staff has got any control in a number of people being sick. And of course, the numbers affect the bottom line. So that's, it's tough to measure performance on that. But, if you look at all the accolades that the hospital has achieved in the last 1 year, locally and on a national level, I think that is something to be bragged about. And the management team, the CEO, I think all should be, and the staff in the hospital should be credited for it. And I have absolutely no hesitancy in extending the CEO's contract by 1 year.
Okay, thank you, Dr. Eapen. Pat?
Thank you. When I look back on this year, I see a year that was filled with challenges and filled with accomplishments at the same time. And in my own personal work life, I evaluate my facilities. The ones that are better are the ones that operate as a team, and it's very visible with the accomplishments and the patient care that is given. And this hospital carries that out perfectly. I think that the accomplishments that we had this year, due to the leadership that we had, demonstrates that everybody performs as a team, as one. And I think that is something that you should all be very, very proud of. And I think that team approach is reflected in the fact that Measure Z passed with such a high percentage. I was not afraid at all that we would pass with 50%. 2/3 is extremely difficult. And I remember that I was told that night, as the numbers came in, when I knew that they were solid and they were holding, and I don't remember doing it, but I guess I was screaming and jumping up and down because other people told me that's what I was doing. I think this is a tremendous vote of confidence of the people in the district and those people that live outside of the district but come here for their patient care, that they see the benefits of the teamwork and the approaches that we have, and they appreciate it, and they also trust us. And I think we need to keep that in mind. They trust us to do the right thing, and we need to continue to do this. And I agree with the measure to extend the contract because it's all due to the leadership that we have here with all of you following. Thank you very, very much.
Great, thank you, Pat. I concur with all the comments that have been made. This has been a very challenging year or two in healthcare, and yet the challenges are going to be even greater ahead. The district has been well served by solid and steady leadership over the many years and actually decades, providing high-quality service and obviously gaining great confidence among our community. So I will concur in the extension of Ms. Farber's contract for another year. And at this point, I'd like to invite any public comment. We'll open this up to a public hearing. Those in the public are free to address the board at this time. Well, seeing none, then I will call the question. And Colleen, if we could have a roll call vote on this, please.
Director Nicholson?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Danielson?
Aye.
Director Egan?
Aye.
Measure passes.
Thank you.
Thank you, Nancy. We'll move on to item B. Dr. Eapen.
Mr. President, in accordance with the district law policies and procedures, I move the Chief Executive Officer be authorized to proceed with the purchase of the Arctic Sun Patient Temperature Management System for an amount not to exceed $45,000. This purchase was included in the fiscal year 2013 capital asset budget.
Great, thank you very much, Dr. Eapen. Do we have a second?
Second.
Second from Dr. Stewart. Nancy, a brief comment about this?
You could probably explain this a lot better than I can, but in simple layman's terms, having a therapeutic hypothermia for post-cardiac arrest patients in the emergency room in the cath lab before they get to ICU will save heart muscle. And it is considered state of the art to do that. And the more heart muscle you save on a patient, the better off they are. This system includes a control unit, disposable contoured pads that are placed on a patient. And this is a big improvement over how we're doing it now, which requires placement of cooling mattresses below and on top of patients like sheets, and doesn't permit skin contact with the cooling sheet. So during the rewarming phase, the Arctic Sun will also control how smoothly the patient's temperature rises, eliminating swings of temperature that we see with our current system. And this is something that we plan for in our capital asset budget. We're a cardiac receiving center. I encourage the board to consider this.
I would agree. Actually, this device is used for cooling patients immediately after cardiac arrest so as to preserve brain function. And currently we do this by very traditional means of a cooling blanket and ice packs and a lot of attention to cooling measures. It's old technology, but it does work. New technology is out there. The beauty of this technology is it really does work, and we actually have patients who, after prolonged cardiac arrest, actually are able to leave the hospital walking and talking. It is absolutely stunning to see that happen. There are a lot of good stories about this at this hospital. So I think this is a good investment because this will allow us to do this even more effectively and get even better outcomes. So I'm going to call the question. All in favor?
Aye.
Aye. Any opposed? Motion passes. And at this point, we're going to adjourn to a closed session. Okay, we're going to reconvene to open session and announce that no action was taken in the closed session. And is there any other business before the board?
Happy holidays to everyone.
Seeing none, we all wish you a wonderful holiday and Christmas season and a wonderful new year. We'll see you in 2013. Thank you. This meeting is adjourned.